I'm going to now introduce Dr. Ashrith Guha. He's one of our colleagues, and at first he's going to talk about LVADs and mechanical support more in detail, filling for Dr. Brian Bruckner, who's actually in the OR. Okay.
Thank you, Dr. Park. Welcome everyone. So, in the interest of time, we'll try to go and finish all of this in about 10 minutes. You know, each of these is almost a day-long symposium, so I'll try. Again, I'm filling in for Dr. Bruckner, who's in surgery. So, really, the objectives are to give you an update on, what are the indications for a permanent LVAD, and talk about the device strategies in terms of bridge to transplant and destination therapy, look at some of the clinical benefits and contraindications. So, really, the first thing, again, this is our advanced heart failure team. We'll skip this slide and go straight away to indications for advanced interventions. So when you're looking at patients who need either an LVAD or transplant, you're looking at patients who are in stage D heart failure. It's defined as patients who have refractory heart failure symptoms, refractory to any medical therapy, and persistently have NYHA class 4 symptoms. And the other things which objectively that you can do to ensure that they are in end stage are things like right heart catheterization, which show an elevated wedge pressure and decreased cardiac index, in the absence of inotropes, and also a cardiopulmonary exercise test, which can show you a peak oxygen consumption, and if it's less than 12 or definitively under 10, suggests that these patients are in end-stage heart failure with really poor prognosis in the next 6 to 12 months. And these are the patients in whom you should consider any of these advanced cardiac therapies, which is transplant or LVAD. So, the big thing with transplant is that the donor heart supply is limited. Now, in the last couple of years, though the donor supply has increased a little bit, but still it's in the realm of 2,500 or 3,000 donors a year. So, whereas there are about 16,000 patients on the wait list. So, it's only about 1/8 the number of patients that are waiting that you have hearts available. And, even with heart transplantation, 1-year survival is about 89%, 5-year survival is about 75%, and 10-year survival is about 55%. So what can you offer these other patients who are on the wait list and potentially, either not, either too sick to get transplanted or can't wait for a heart transplant? And we now here, this is a list of patients who can't get a heart transplant for various contraindications, such as elevated pulmonary vascular resistance, advanced end organ disease, or cross-match incompatibility due to which they can't wait for too long, or relative contraindications such as age, malignancy, and size and obesity. So, that's where the mechanical circulatory support or durable mechanical circulatory support came into being. Now, the first trial for this was in 2001, where a pulsatile pump, which was HeartMate XV, was compared to inotropic therapy and was found to be superior. And since then, as you can see here, the number of patients living with LVADs continues to rise. In 2008, a continuous flow LVAD was compared to the historical pump, which was pulsatile pump, and was found to be superior to that. So from 2008 onwards, you can see that the number of continuous flow LVADs are increasing every year. So again, this is from the Intermax database. This is a database of all patients with LVADs. And as you can see here, compared to the previous generation LVADs, the 1-year survival here, with continuous flow LVADs is up to about 81%. And, this was a study which was looking at seeing whether, if you can give these patients LVAD, can you put off transplant for, for some time? And overall, the message from the study was that at least in status 2 patients, this was really not inferior, which means status 2 are patients who are stable at home. So I think in the interest of time, I'm going to just skip this. So in terms of, what happens to patients who get an LVAD and then go on to get a transplant, again, these patients do as well as those who've been transplanted without an LVAD. So the message again here is that if patients cannot wait for a transplant just with medical therapy, then it's ideal to get them to an LVAD so that they can wait safely and then go get a transplant. And this is again from the Intermax database showing that that about 88% alive at 1 year when you do LVAD as a bridge to transplant indication. Now, currently, as of 1 or 2 years ago, this whole bridge to transplant and destination therapy has undergone a little bit of revision where there are really only 2 indications per Medicare, where either you're bridge to transplant or DT. Earlier on, there used to be another category called bridge to decision, which we have gotten away with. Again, this is now switching gears to destination therapy. Destination therapy is when you are implanted with an LVAD as your final end organ intervention as far as the heart is concerned. And as we get more comfortable with the pump and as more centers implant these, more and more centers are implanting LVADs as destination therapy. And again, when you look at destination VAD therapy survival, it's improving every year, and now we are close to about 78 to 80% survival. Now you have to realize that a lot of these patients are actually not transplant candidates, so a lot of them have contraindications to transplant. Hence, these patients' survivals is expected to be lesser. But if these are patients who otherwise would have lived probably 6 months to a year, so their overall survival would have been about 25 to 50% at 1 year, and now you're giving them at least 80% 1 year survival and almost 65% 3 year survival. And LVADs also give you a good quality of life, and as you can see here, the quality of life continues to improve and usually hits a plateau around 12 months, but the quality of life improvement that people get stays about the same. So that's important to know, because if they get improvement for a few months and then starts to go back down, then that's not ideal. Again, the big thing with any of these end organ interventions is that they do come with their set of problems. If it's transplant, you're dealing with rejection, infections, and graft failure, whereas with LVADs, you are dealing with risk of bleeding and clotting. But all these adverse side effects have been decreasing over time as we get more familiar with the pump and we get better at managing these complications. So in terms of the patient profiles, like Dr. Estep mentioned, the critical cardiogenic shock patients are not the ideal patients to do any durable end organ intervention, whether it's transplant or LVAD. And these patients are decreasing with time as more temporary mechanical support options become available. A lot of these patients are getting those devices as they get better and then getting durable assist devices. Again, the reason not to do it is you can see it on the graph here on the right, where the Intermax 1 patients do not do very well after a durable LVAD. Again, what are the contraindications to implantation of a long-term LVAD? Severe hemodynamic instability, irreversible major end organ failure such as ESRD, or patients who are on home oxygen because of end-stage COPD, major coagulopathy because all the patients with an LVAD have to be on antiplatelet and an anticoagulant, and significant right-sided heart failure because these are univentricular device for the most part, and the patients with significant right-sided heart failure do not do very well, both in the short term and long term. And again, uncertain neurologic status, people who are on a ventilator and comatose, they should not be getting any durable device. And again, prolonged need for mechanical ventilation is not, these are patients who should not be getting an LVAD. And again, sepsis or vasodilatory syndromes, these patients do not do well after going through a cardiopulmonary bypass. So these are some of the patients who should not be considered for a durable LVAD implant. Again, this is Metamax, which looks at 12-year event-free survival in patients who are on medical therapy. And compared to 2001 till now, 12-month event-free survival in end-stage heart failure patients has not really changed much. Still about 50%, all people put together. So again, that's why we make a case that when patients enter end-stage heart failure, they should be considered for durable interventions. I think I'm going to stop here for this talk, and I think we'll go to the next talk, please.